All right, everybody. Welcome back. We're going to go ahead and get started. It's good to see you all again. Hopefully you can you guys hear me? I got to make sure my video and audio is good. Today I'm in a little different environment. As you can tell, this isn't my normal front room area. Um, I had a meeting today at work that I had to attend, and it was kind of back to back with this lecture, and so I'm actually at work today and taking my lunch break to do the lecture. So we'll see how this goes. I've had to do this once or twice. Most of the time it goes fine. As we go along today, please let me know if I cut out suddenly or if my voice goes out or it mutes or something because I'm using hospital Wi-Fi and it's done pretty good in the past, but once in a while we have an issue. So just if something happens, just let me know right away and I'll cover it back or make sure we can get good get good internet connection. So a couple of things I wanted to cover before we kind of got into lecture is just kind of a pacing thing of where we're at in the class. Remember that you had your module, and for section one, it had A and B. I'm seeing some of those come in now, and that's great. I'll get those corrected and looked at and given points for. Just as a reminder to you guys, I've not given you some due dates on the modules. But my recommendation, of course, is that you try to keep up as we do a lecture, you do the modules at the same time and hand everything in together. Now, at the end of the class today, your test should be available. And the first test is going to cover module one, and it's going to cover both A and B on the section. So keep that in mind. So that'll be the first two lectures, and that'll be available right after this. So what my recommendation again would be is that, of course, do those modules and everything before you take your test, then take your test, and try to have all of that first half of everything completed before we meet again. That's kind of the recommendation to keep up. Now, again, as you guys know, I'm one of those guys that understands you have a crazy life right now with clinicals and work and school and everything you're doing. And so that's why I don't give you hard, fast due dates. But please try to keep up. It's so much better to keep up with the class than kind of panic at the end and call me with issues. So I'd appreciate if you would try to do that. Let me think. Anything else I wanted to cover for business stuff? I don't think there is. Is there any questions before we get started on anything that's just like class related, not necessarily with this lecture? Questions you had, things you've run into? Okay, I'm going to take that as a no. Um, as a reminder that I always give you guys, as I'll get into the lecture here, I'll be talking a bunch. I think I've had a little sickness. My voice is a little weird. So I love participation, as you guys know, and I love when you interrupt me. And as you also know, I don't pay attention really well to the hand raises or the text. So if you have something to say and you have a question, just interrupt me at any time. I'm totally cool with that. Okay. So let me get my slides set up and then we will get moving here. Okay. So if someone will let me know, are you guys seeing the full presentation screen? Looking good? Okay. One other question I have that sometimes when I don't have my dual monitor set up that I screw up is, can you also all see your faces on the screen, or are you just seeing my slides? Dallin's saying yes. I'm going to say just the slides, right, Dallin? Okay, awesome. Then I'm going to minimize your faces on mine and we'll get moving along here. Okay, so like I said, this is section 1B. Today we're going to be covering gated blood pool studies, also known as Muga scans. So let's get into it. Okay, So MUGA, the term MUGA is an acronym and it stands for multi-gated acquisition. So today we're going to be talking about blood pool studies. When we say blood pool studies, what we mean by that is we are going to be imaging the blood that goes into the ventricles of the heart. Specifically, we're going to spend our vast majority of time on the left ventricle, but of course, we can see some right ventricle, we can see some atrium, but we're looking at ventricle, and it's the blood flow through it. Now, make sure that you understand the delineation between a blood pool study, which is the pooling or the blood within the ventricle, and a myocardial perfusion study, which is the blood that goes through the coronary arteries and into the muscle itself. And that's what we do with when we do stress testing and perfusion studies. Okay, so this is the blood going through. I've put down here some of the common indications for or reasons for doing a blood pool scan. The first one is determination of ventricular ejection fraction. We're going to define here in a minute more what ejection fraction means, but ejection fraction in a basic nutshell is the contraction of the heart. We're going to be able to measure how efficient the heart is functioning. The other thing that this helps us evaluate is ventricular wall motion. And what I mean by that is even though the ejection fraction is going to give us a number of how well the contraction's happening, we can also look at the individual portions of the cardiac wall, the ventricular wall. So we'll be able to see what the lateral wall is doing, what the apical side is doing, what the septal side is doing, and are there differences in how those contract and what they're doing and what kind of motion they have, and what does that tell us about what's going on with that individual's heart and how it's functioning. And then the other one that we do this for is pre-chemotherapy. So there are types of chemotherapy drugs that can lead to what they call cardiac toxicity. And basically that just depresses or reduces ventricular function. It can lead to what basically looks like heart failure. And so oftentimes what they'll do is if they're going to put someone on chemotherapy, they'll have them come get a Muga scan in advance of that chemotherapy so that we can assess the wall motion and we can assess the EF and the function of the heart. And then that way, when they get the chemotherapy, they can have them do follow-up appointments during that chemotherapy to see how the function of the heart's doing, to see if they're having this problem with the cardiac toxicity, and make sure that the patient can remain healthy enough to be able to do the chemotherapy. Some sites will do this pre-chemotherapy and then they'll do follow-ups. I've also seen other sites that they just do it as a follow-up. They don't do one in advance. They just do a follow-up after chemo to see if the heart is handling it. You'll see a few different things like that. I will say from the outset also about Muga scans is that you don't see as many of them as you used to see. Um, they're they're done still a few here and there, but Echo has taken over a lot of looking at wall motion and ejection fraction and how the heart beats. They've kind of gotten ahead of us a little bit in their technology, and so a lot of what used to come to us as a Muga scan is now going over to Echo, but you should still see them. Also, another thing to keep in mind with that is that usually if a doctor starts a patient out on one modality, they're going to stick with that modality. Those modalities, when we start talking about an ejection fraction percentage, those modalities can be slightly different in their measurement of that ejection fraction. So in other words, if you have an ejection fraction on a Muga of 55%, and then you go over on echo and it's 65%, that doesn't mean that it increased or anything like that. They're just, you have to compare apples to apples. So typically, if people have had Mugas in the past, they'll probably stick with the Muga. All right. So we need to talk about multi-gated acquisition. Remember, I said Muga stands for the MU in multi, and then gated acquisition is your GA. So what do we mean when we say multi-gated acquisition? Oops. Um, if you remember last time, we talked about the R to R interval. Okay, so I swear we skipped a couple of slides here. Where'd it go? What in the heck? Hold on one second. I'm gonna look at something. I had two slides missing that are deleted. What the heck? Hold on. Let's make
I
sure I
think
got the right
the
one.
one that you listed for us that like the second slide is like, what does it mean to gate?
Yeah, yeah, that's what I thought. I'm like, wait a second. I've usually just roll along with this lecture, but I'm seeing two missing slides. I'm like, well, what the heck happened to them? Let me see if I can actually do like an edit undo. I wonder if I was in here and accidentally. Oh, there we go. There's one of them. And okay, so now we should have that slide, that slide. Okay, I think that's the one. Does that look like your paper that you guys have now?
Yes.
Awesome. Okay, good, because I want to talk about what gating is first before we just get into dividing everything up. So, okay, sorry about that. I must have accidentally deleted when I pulled it up. So then let me ask the question, now that you brought it up, what does it mean to gate? When we say gated acquisition, what does that mean? Who wants to take a stab at it?
Think it's basically that you're timing the moment that you acquire data based on a certain point in the patient's EKG.
Yeah, Dallin, that's absolutely right. So last time we met, we talked about the R to R interval, right? And so when you set up a three-laid, and you know what, Dallin, before I do that, I'll just give you your definition was almost exactly with the one that I kind of textbook definitioned here. But gating is an imaging technique that uses the signal from EKG leads to obtain acquisition data during certain timed intervals of the cardiac cycle. Pretty much exactly what you said, just a different word. But yeah, if you remember the R to R wave, we talked last time about EKG and that R wave. When you set up a gated acquisition, you're going to have three leads, and I have those right here. Typically, you'll have a right arm, and left leg. Sometimes you'll have a fourth lead, which is usually the right leg, but typically you see this three lead setup. And so what this three lead setup is doing is it's trying to find your R wave. It's looking at the complete cardiac cycle, but the camera is designed to look for that R wave. And then what happens is it takes that R wave and it splits it up into frames. Okay. So these are what are your timed intervals. Now, for simplicity purposes on this slide, I've only got 5 frames. So each of these is broken up into 5 frames. 1, 2, 3, 4, 5. Okay. And that's from our R to R. Now, I want you to go back in your mind and remember last semester when we talked about how our camera can do what's called frame mode or list mode. You remember me talking about list mode? So list mode is when your camera can acquire data and then it can take portions of that data and assign it what looks like an address. And so it can put stuff in lists for using later to recall or to rebuild something. And so in this case, what happens is each one of these frames, so if we have 5 frames, and just so you know, you would never do 5 frames. Usually most cameras do like 16 or 24 frames. I just did this for simplicity. But if we have these 5 frames, essentially frame one would be taken out of this particular beat and out of the next beat and out of the next beat and out of the next beat. And it would all be assigned to that list mode or that address for that spot. Then the second frame would do the same thing, third frame, fourth frame, and so on. What this allows you to do then is to go back to your camera and say, I would like to see everything that is just over the QRS. I would like to see everything that's just over the T wave or where that relaxation occurs. And what that means is that if I ask the camera, I want to see everything that's just on the QRS complex, please grab from those addresses from that list mode and build me a picture based on that. Then what I'm going to see is I'm going to see the ventricle only contracted. It's going to be a static image, not a moving image, but it's going to be a contracted image. Why? Because I built everything, every one of those frames for the whole, 5 minutes or whatever that you imaged. I built that all on that portion where the QRS was contracted, where the ventricle was contracted. I can do the same thing for if that's systolic, I can do the same thing for diastolic, right? And then I'm able to take those two and compare a systolic picture of the heart to a diastolic picture of the heart. And now we can start drawing ROIs and measuring things and seeing how many counts and blood flow is within those ventricles. And so that's the main idea behind gating. And what you'll have is that you'll usually have, so this is like more realistic, this picture. I broke it up into 16 frames. We have a camera that does 24. Like I said, common frames are 16 frames a cycle. And what you see here is about 250,000 counts per frame, and then imaging 100 to 300 cardiac cycles. Now, let me make sure that I define what that means so there's not confusion. I don't mean that in each of these frames on an individual heartbeat, there's 250,000 counts. That's not possible. A heartbeat happens too quick. You're not going to get that many counts, right? But what I'm saying is that for frame one, if you take frame one and you take it for all the, 300 heartbeats that you had during the acquisition and you put that all into one, now you start to see that you have, a bare minimum. This is bare minimum of 250,000 counts. As you guys have known, because you've done statics with other things like bones or HIDAs or whatever, it's typical that, 250,000 counts is probably your low end. You probably get like 500,000 counts or 750,000 counts for a typical image. So in this case, I listed the lowest that you would go. What that means is that depending on how many counts you ask there to be in each frame and how many frames you do within the cardiac cycle, that can make your image longer or shorter. It can make you need to get more heartbeats to build those images or less heartbeats depending on what your protocol is. So my recommendation to you on this and really understanding it is go grab one of your techs, maybe one that's like, more kind to being patient with students, and see if they'll go into their Muga protocols with you, because you should be able to go in and see how many frames they're using, how many counts they want per frame, whether they've just based it on counts per frame or whether they base it on time and then they, get about enough counts to form images. Go in and look at that. That'll help you understand it. But the basic idea is that we're just breaking up the cardiac cycle into frames. We're using those frames to form images based in those timed intervals. Any questions on that so far? Okay, awesome. Um, so I brought this picture up. This picture's from our last lecture. And the reason I brought it up is I just want you guys to be able to kind of look again and again get in your mind a view of the chambers of the heart, and just to remember that you've got your right and left atrium, you got your right and left ventricle. Again, atria contract at the same time and ventricles contract at the same time. And so, as I said before, what we're going to be looking at is the blood flow inside of these chambers, right? Not the cardiac muscle, not the myocardium. We'll do that when we do stress testing. This is what's going through these chambers and how well they're able to contract. So if you think about that for a minute, when we talk about perfusion, we're going to give them something like sestamib that will go into the heart muscle and be attracted there. This is just what's in the chambers. And so if you think about it, we've got to get radioactivity in those chambers to measure them, right? So the only way to do that, because blood is what flows through the chambers of the heart, is we've got to have a way to make blood radioactive so that we can get counts and we can image it. And so that's what we're going to go over next. Is talking about the radiopharmaceutical. So the radiopharmaceutical used for gated blood pool imaging is going to be TEC, just regular pertechnetate. However, it's going to be tagged to red blood cells, okay? And so what I'm going to show you now is what's called an ultra tag kit. And this is what allows us to take our pertechnetate, have it tagged to the blood cells only, and then obviously then wherever the blood goes within the body, we have a way of imaging that, okay? I put 140 keV up here. I don't even know why I put that up. By this point, you guys know it's 140 keV. But this is our red blood cell kit. Now we're going to look at the Ultra Tag kit. In all of my time in nuclear medicine, I've never seen anything else but this Ultra Tag kit. I did have a student once tell me they had another brand. I don't even remember what it was called, but I'm going over this one because I'm willing to bet that 99.9% of you, this is the kit you're going to use. If you find another kit, the same chemicals and principles that I'm going to teach you right now are involved. It just might look a little different. By curiosity, is there anybody that has seen anything other than an Ultra Tag kit for labeling red blood cells? Okay, you take that as a no too. All right, so let's get into it. So when you open up the kit, this is the kit here. It'll come from your radio pharmacy. There's kind of three different parts to the kit, but essentially what you're going to do is you are going to go to your patient and you're going to draw 1 to 3 ml of whole blood into a heparinized syringe. There's a process, and there's time from the time you draw to when this kit is made. And so it's important to go into a heparinized syringe because depending on the patient, what's going on with their clotting factors, what's going on with their health, you can get some patients' blood who's clotting very quickly. And so you don't want that to happen. If you try to prepare an UltraTag kit with clotted blood, it won't work. So we want to make sure that you have a heparinized syringe. Some places that you work at will actually have syringes that come pre-heparinized, and those are fine. If you don't, a lot of places will have heparin in a vial, and honestly, usually you can just draw some heparin in and push it back out, and the syringe itself is coated enough that it's heparinized for the small amount that you're gonna draw out. Talk to your techs and see what you do at your facility because it might be specific to your facility, but know that it's recommended and wise to use a heparinized syringe. So once you've drawn your blood and inside the kit, you're gonna have a reaction vial, which is right here, and it's labeled reaction vial. And then you're gonna have two syringes, syringe 1 and syringe 2. Um, Initially, you're gonna come in and your blood is gonna be injected into this first vial. Now, when you draw your blood and when you're working with blood, it's kind of finicky. If the blood cells don't keep their membrane, then they won't work for tagging. The blood cell has to have a blood cell membrane to work for this process to work. So what that means is that we have to be gentle with the blood. You don't want to be shaking it around and forcing it around and doing anything crazy with it because it can break down really easy. So as you're putting that blood into the vial, that means that when you put it in, you're not going to want to just push it as hard as you can through the needle really quickly. If anything, you can kind of tilt it and let it slowly kind of drain in, just nice and easy, nothing crazy and hard and quick. You don't have to push your plunger really hard or anything, just like nice and easy. And that's just going to make it so that the blood is pretty much babied and doesn't have a problem. The other thing I would recommend is when you're drawing this blood, that you use a larger needle size, and then when you're also transferring it, you use a larger needle size, and that will just help protect the blood cells as well. So let me tell you what's in the reaction vial. You have stannous chloride and tin chloride. Those are the two chemicals in it. What both of these chemicals do is both of these chemicals are able to diffuse across the red blood cell membrane. Okay. So when you put the blood in there, what's initially happening is those chemicals are going through the blood cell membrane. This is why I said it had to be intact because you want those materials to go inside and to basically make it so that that red blood cell has the stannous chloride and tin chloride in it. Why we do that is because both of those two bind to Tec. Okay, again, I'll say that again. Both of those bind to Tec. So that means, again, we want a way to get the blood radioactive. So in order to do that, stannous chloride, tin chloride across the blood cell membrane, and they can bind to Tec. Okay, so that's the first thing you do. And notice we haven't put Tec in yet. That's just the principle of it. Just those two things go in. With the syringe, or with the blood inside there, you can tilt it back and forth a couple of times just gently to make sure it kind of mixes together. The next step is you're going to take syringe 1 and syringe 2. And as you might guess, it's labeled syringe 1 because you do it first, and then syringe 2 is second. These two have sodium hypochlorite and sodium citrate. And what these do is they oxidize extracellular stannous chloride. They make it inert. And what that means is that when it's inert, it's unable to bind to Tec. So think about this for a minute. Why would I want to? I just went and put stannous chloride in so that we could bind Tec to it. Now I'm putting something in that is going to make that stannous chloride ineffective. And the key word here is extracellular stannous chloride. Okay. So what has happened is you put the blood in, a certain amount of that stannous chloride and tin chloride has crossed the cell membrane and into the blood cell. And so what we're talking about here with syringe 1 and 2 is we're just getting rid of anything that isn't inside the blood cell. And that makes sense because once we put tech in, we don't want tech binding to anything outside of the blood cell. If it does that, then we've kind of lost the purpose of what we're doing because we'll have free tech floating around, right? And you only want that tech tagged to the blood. So that's what syringe 1 and syringe 2 are doing, is just making extracellular stuff and getting rid of it. At that point, then you can add, I put 25 millicuries of tech here. That's going to be a little bit dependent upon what your protocols are. Um, Most places I've seen are somewhere around, 15 to 25 millicuries of tech. So that will be a little dependent there. Once you get the tech in there, you can then agitate it gently again. Again, we're not shaking, we're just tilting it back and forth to make sure it mixes up a little. And then we want to set it aside, and it needs to sit for at least 20 minutes for the tagging to take place. What's happening at this point is the tech is going in and it's searching for anything to bind to. And in this case, it's going to bind to the red blood cells that have stannous chloride and tin chloride in them. Okay. So you want to let that sit about 20 minutes. Um, the packaging insert does not give a direction on how long you have after that 20 minutes to get it into the patient. I have heard people say over time, get it in there within about 15, 20 minutes from that time. My recommendation to you guys to get a good tag and to make this happen correctly is time things out so that at the end of that 20 minutes, you can take it immediately and go put it in your patient. Now, you don't want to put it in before that. At least give it the 20 minutes. But if you're going to err on the side of completing that 10, 20 minutes and then getting it back into your patient as soon as possible. Okay. Any questions on UltraTag kit preparation? Have any of you done this yet?
I've mixed the kit, but not for like Muga.
Is it for a GI bleed?
Yeah.
Okay.
I've only seen one Muga. Apparently, we only do them a few times a year.
Okay. Yeah, and you're right, Jesse, and that's relatively typical. Like we see a few more here, just because we're kind of dedicated cardiac, but like, yeah, you don't see a ton of these anymore. But it is on board, so we have to make sure you guys know how to do it. But you're right. These are also done for GI bleed. Anything that you use where you're using tagged red blood cells, it's going to be this same process. So this is maybe some of a repeat from learning about the GI stuff as well. But cool, awesome. Thank you for participating, guys. Okay, so let's get now to the procedure and kind of how this is done and what we do. So once you inject your patient, again, you can pretty much image right away. You don't have to wait or anything like that. Just inject the patient and then go ahead and get them on the camera. In terms of the camera, we're using low energy, high resolution because, again, we're using tech, right? It's just a tech product. And so those are the camera heads that you'll use. We're going to position our patient supine on the gamma camera, and we're going to put the arms above the head. Now, you'll see a couple of different pictures we do here on a Muga. This can be done if it needs to with the arms down. It's just much, much better when we have the arms up. Anything, honestly, heart related, because you've got your big arm bones sitting right in the middle of everything. And typically with a heart, we image kind of off to the left side. You're going to want to try to get the arms up. So, in most cases and anywhere where you can have the patients put their arm up, if there's an issue, then you can do it. It just, you have to finesse a little bit. And you'll see that as we get into the pictures that we acquire. So once you got the patient all settled and ready, you're also going to attach your EKG leads for your gated acquisition. Again, like we saw in the picture back there, it's kind of the standard configuration. One thing I do want to mention that I just thought of is that standard, and maybe we'll go back real quick as we're talking about this. That standard configuration of kind of the, right arm, left arm, lower left. That's the way it's designed. Those leads are designed to be in that placement. However, one thing I want you to think about is that these leads are not diagnostic leads. And what I mean by that is that they're not trying to read an EKG for the purposes of saying things like, do I have ST elevation or ST depression? What kind of wave do I have? Do I have a block here? Do I have a bundle branch or anything like that? you're not assessing EKG off of that. You'll be doing that when you do stress testing, of course, with a full 12 lead EKG, but you're not doing that with the 3 lead. The only purpose of the 3 lead is to try to gate. And so the most important thing you can think of with a 3 lead is I need to make sure I get my R to R interval because the camera is trained to look for that R wave. And so that can be the issue. And sometimes that means that you have to move things a little bit. Like, for example, if a patient has a pacemaker that's right up here by the left arm, sometimes you got to move that. Sometimes that can interfere and cause an issue. I have seen where a pacemaker gave us a really good signal, and that was awesome. But other times where it really got in the way. One thing I will tell you as a tip is these leads really like to be over bone when they read. I think I mentioned that last time. So I've had a lot of these where we've actually taken and we've done 2 leads down here and then maybe 1 lead right up here by the sternum. So they're all placed over bone and we get a good signal. What you don't want to have happen is just a really weak R wave. Sometimes I've also seen, for example, when we talk about weak R waves, I've seen an R wave that is really kind of weak because it couldn't get the signal well, and then a T wave that almost looks the same size. And so oftentimes in that situation, what the camera will do is it can't distinguish between what's the R wave and what's the T wave, and it will actually try to show you your gates in between R and T instead of between R to R. And so it can mess up your gating and it can mess up the counts that the camera gets and things like that. So don't be afraid to move those leads a little around a little until you can see that you're getting a good R wave. And most of your cameras, your acquisition stations, are going to have a place where you can switch a page or somewhere in your acquisition station that's going to show you that R to R wave, and you're going to be able to see it as you're setting those up and see that you've got a good signal. Okay, so that's really important. So again, attach those
I have a
EKG
quick
leads. Yeah,
question.
go ahead.
Uh, what causes the R waves to get like super high? Because I know sometimes we have to like open up our window because we have like a 20% window for our R wave and we have to open it up to 40% for certain patients.
Are you
Otherwise,
talking
the
about
beats will get rejected.
are you talking about how big the R wave looks?
Mm-hmm.
Okay. Honestly, it could be some different conditions with the heart in terms of how it's contracting. You can have hypertrophy in the cardiac muscle that makes the R wave look really large on an EKG or that makes it much bigger. I'm not sure I know what you're talking about with the R wave and the 20% window. Are you talking about what the camera accepts as a beat?
Yeah, with like the
Okay.
gating on our camera is
Yeah.
like if the R wave's too high, like out of the 20% window, it rejects the beat. So sometimes we have to open the
Yeah.
window for it to accept
Yeah,
them.
so your camera is looking for that kind of perfect R to R. And if it doesn't see it, there's settings on your camera where you can say, okay, if this looks really out of whack compared to the last one or compared to other what else you're seeing on leads, then it can accept or reject it. And so that is part of looking at that R. Not only do you have an R to R wave and that it's seeing it, but also is it accepting it as a full beat. Your camera will try to it'll try to look at the best beats it can and accept ones that it looks like are good solid beats and reject the other ones. And so that's what you're referring to. So
Okay.
a lot of times it's just heart rhythm issues. But that's why I told you guys really don't be afraid to move your leads because sometimes it's just how the lead is seeing the wave. And it can really cause issues over patients that have a lot of adipose tissue. You can get a really weak wave. And so yeah, don't be afraid to move things around until the camera sees a good gate and is acquiring data and accepting a lot of those beats. So yeah, good question.
So then to kind of go off of that, how do you know how to move the lead or where to move it to or how to make it better?
It's a good question. What I want you to think about with this picture is what the leads are doing is they're triangulating, which means that you've got your heart beating kind of right here, just to the left side of the sternum. And so the reason they set it up in right arm, left leg is because what the camera tries to do is it looks at what the signal that every lead sees. And remember what I said before, all a lead is seeing is basically like an electric signal from motion of the heart. So when the heart goes towards that signal and the beat goes towards that signal or away from that signal, that's an up or down, right? And so what the camera is doing is it's looking at all three and it's trying to triangulate kind of where that signal is coming from and then choose the best. Some cameras will actually take the 3 leads and it will combine and say, this is what between these three leads, this is what I think that it looks like, so that it has a good signal. Other cameras, you can actually, there's like button and you can push and you can say, pay attention mostly to the right arm, pay attention mostly to the left arm, pay attention mostly to the left leg. And so it's trying to triangulate. So what that means in thinking in terms of how do I get this better is if you set it up like this and it's an issue, the first thing I would be thinking to myself is, okay, patient habitus. Like, is the left leg one clear down on someone's belly and they're a larger patient, they have a lot of adipose tissue? Is that screwing it up? If maybe it's that one, these two are doing okay because they're up by rib, but that one's throwing it off. And so it's making it kind of tweak out because again, it's trying to look at all three. So if you take that lower one and you move it, say you could move it right up to sternum. So you have sternum, right arm, left arm, and then look at it and just say, okay, is that triangulating better? Sometimes I'll move it over to the left. I've had all three down below the heart before. Again, as long as you get an R wave signal that it can look at. So it's really a lot of it's trial and error. But I would say start here, of course, and then just think of the fact that I want every one of my leads to be able to see the signal good, right? And I don't want all my leads in the same spot because they're only going to have one option at that point to choose what a good signal is versus if I've spread them around and they have different angles they're coming in on, now the camera can say, what do I like? Can I form something out of these three that makes sense to me? Can I make it so we see a good R wave? Did that answer your question? Bree, did that answer your question? To help?
Yes, it did. Sorry. I didn't know you
Okay.
can see my camera.
Oh no, you're all sorry. Yeah, I only got the one screen, so I turned off the cameras. Otherwise, you guys would be on my slides. Sorry about that. Yeah, I'm not seeing you guys right now. Okay, cool. Awesome. Okay, so we're gonna acquire planar images. We're gonna do one image at LAO 30 to 45 degrees. And typically you'll also do an anterior image. And then some departments will also acquire all the way to the left or a 70-degree LAO. Now I know that's a lot of options. Let me show you why we're trying to go to the left a certain amount of degrees, and that will make more sense. I would say on a question for, say, a boards exam or something like that, if it asks you what image you require for a gated blood pool, you're going to say LAO 45 degrees. Okay. But you're going to see that 45 degrees has variation, and that variation depends on what we're actually trying to get for the image. And I'll show you that here in just a minute. Okay. So this is what an image looks like, and I realize this looks kind of like just a blob, messy blob. So let me kind of try to identify some things for you. First, let's talk about where we expect to see distribution from a tagged red blood cell. Obviously, you're going to expect to see heart, so I'm going to identify that first. So your right ventricle is here. I could probably extend this arrow down just a little further because it's right in this neighborhood right here. Okay, so there's your right side. Your left ventricle is over here, and you can see that that's kind of the brightest thing on the screen, which is what we should expect. Remember, like I've mentioned before, that left ventricle is the largest chamber. And so obviously we're going to have a lot more blood flow in there, so you can see that left ventricle. Other things I've identified that you should see with red blood cells is spleen. So that's going to be down here to the left. Again, the spleen it is highly involved in blood flow and cleaning blood, all that kind of things. A lot of times, there's actually a large percentage of your blood flow in your body when you're at rest that lives inside your spleen at any given time, right? So we should expect to see spleen show up. The other thing that you're seeing here that I want to point out is the septal wall. So again, we have our right ventricle here and our left ventricle here, and then this section you see in the middle is the septal wall. We'll talk more about this. This is really important. You need to be able to see the septal wall to get a good image here. And then, oops, go back. And then other things that I've identified on here is what you don't want to see. Okay, so I want you to think about our whole process here is dependent upon whether we can get our tech to be inside the blood, right? And that's what we call a good tag. You'll hear people say that. Did you get a good tag? Well, if you pull up and your picture looks like this, and you can see the ventricles, you can see the septal wall, and you can see the spleen, those are your keys to know you got a good tag. That's the kind of thing that's going to be on the boards. How do you know you've got normal distribution in RBC when you're doing a Muga? Well, you're going to be able to see heart. You're going to be able to see major vessels. I didn't point out the major vessels up here, but that's what you see up here is like aortic arch. And you're going to be able to see the spleen. Those are the things that you should expect to see. What you don't want to see is normal distribution of tech. So if you pull up your picture and you're like, man, where's the heart? I can't really locate it. And you're having a hard time. You're thinking, what's going on? The first thing you should do is say, okay, do I have activity in the stomach? Do I have activity in thyroid? Do I have activity in salivary glands? Now, you can't see the thyroid and salivary very well up here, but if this picture had activity, you'd probably see a little bit of thyroid kind of right there on that lower end. The other thing, obviously, that you can easily look at is stomach. And you can see right here, here's your stomach right here. You actually have a little bit of almost like a blackened or blacked out spot right here. That's your stomach. It's going to be located just right underneath that left ventricle. So again, if you pull this up and you're having a hard time seeing heart, but you can see a nice bright stomach, that means you did not get a good tag. Okay. Any of those, if you see any of the normal tech distribution stuff, again, renal and GI or other ones, that means you didn't have a good tag. Okay. I can almost guarantee this is a question in my test. I can almost guarantee this would be like a boards type question is how do I know I had a good tag? What should I expect to see if I had a good tag? What should I expect to see if I did not get a good tag? Okay. Also in your module, I asked a question that went something along the lines of um, showing the protocols and asking what can go wrong. This is what I'm looking for when I ask you what can go wrong with a Muga scan. Obviously, you can do a lot of things. You can take wrong pictures, blah, 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 blah. But the main real thing that kills your exam is if you don't get a good tag. And so I want you to be able to look at a picture like this and identify, yes, I have a good tag, or no, I don't. And I know I don't because of I can see these other things. That's what can go wrong. Okay. Now, I want to talk more specifically about the septal wall because it's super important in what we're trying to do here. I realize in this picture, maybe some of you can see it well. If you're on a computer, you should be able to see some dimming right in between those ventricles. If you're on something smaller, you probably can't see it very well, but we're going to try to look at it even better. So I have a picture here, and I actually put this in a 12-step color. In our department, this is actually the way we view it. Our docs want to view it in this way because you can see things better. But you'll notice here you've got the left ventricle, you've got the right ventricle, and you can see the septal wall, this break in between those two. So when I talked a minute ago about the reason for getting a 45-degree LAO, that's what you're trying to do is you're trying to visualize that septum and separate the right and left ventricle into their own spots because we're going to be doing ROIs. And if we have them superimposed, then we're not going to be able to get accurate ROIs. Most of the time, I find that this is a little, on most patients, it's a little shallow of 45. Often it's just a little under 45. But again, I don't want you, when you're doing this as a tech, don't just get up there and be like, oh, I need to do a 45-degree picture. That's not going to help you. What you need to do is get up there, move it to somewhere close to 45, and then you're going to look at your screen. You should have on your camera somewhere that you can kind of see a live image of what's going on. And what you need to do is you need to move your camera until you see that septum, until you can see that separation. That's what you're after. And I have a little video on here just to give you kind of a visualization of what's happening. So you're not looking at like a nuke picture. Oh, that's the other thing I did. I put a little line right there. So if you couldn't see it, you can see it right there with that little, that's right where it is. So I'll go back and forth there. You can kind of see it fill in. So it was hard to visualize. That's where it is right there. It kind of curves up and around. Here's our this little GIF, this little image. Hopefully you can see it good. Maybe it'll pull up and maybe it won't. There we go. So you can see it turn. So it's going to turn back and forth. So as you roll your camera to the left, what you're doing is you're straightening out those two chambers, and you can see right down the septum there. So that's what's anatomically happening as you're doing this. Okay, hopefully you can see that. We'll let you rewatch it again later if you didn't see it, but that's what you're trying to do. Any questions on the LAO image, why we do it, and what we're trying to do when we do that image? Okay, And remember, I can't see you guys, and I'm also not looking at your other stuff right now. I just have the one screen. So just shout out if you got a question. Okay. Here's a 70-degree LAO. This is in our department here. We do a 70, and sometimes we do a lateral depending on what the doc wants to see. This image isn't as important, but one nice thing about this type of image is that you can really, really see that left ventricle well. You can see its shape and size. So remember how I told you last time how the heart sits? You've got the apex, which is like the bottom of the cup, and it kind of sits forward, right? So that's what you have here is this is the apex, and up to the base or the rim or the top of the cup kind of sits to the back. And so that you can see that really well here. So this is a really good image just to see the size and shape. You're not going to want to do an ROI on this image because if you did an ROI right here, you've got right ventricle in the background. So it wouldn't be accurate to just the left ventricle. But it is a very good image for kind of seeing size and shape and seeing that you've got that left ventricle and that you're looking at the right thing. So what I've got here is I've got the 24 frames and I've separated them out so that you guys can see. Our docs actually don't require this picture when we do it. Some of your docs might want a picture like this, but I wanted to show you this picture because it really shows the contraction or the motion of the ventricle. So hopefully this isn't too small that you can see it, but you can see the left ventricle here. And on frame one, basically this ventricle is nice and full, which means that we're at diastole right now, right? So we're diastolic. And as we move through these frames, what you're going to notice as you go more and more, you can really start to see it in five. It gets a little smaller. Six is smaller, keeps going smaller and smaller until you get probably out to this ninth frame here. And now you can see that it's quite contracted. If you look back at frame one and then go to frame nine, you can definitely see that the heart has contracted, and we're seeing that contraction of that left ventricle there. That's exactly what we're seeing. And then you can see as you go on, actually, it might even get smaller down to maybe even 14, but all the way through all of these, it looks fairly contracted. And then as it goes on through 17, 18, 19, and all the way back up to 24, you can see where it's filled again. So there's what your frames look like. And I wanted to show you this picture because remember I said they're breaking up that cardiac cycle into frames. And so this would be every frame number one throughout your entire acquisition put together so that you can have an image that I don't know what the counts are on here. I probably should look at that, but they're probably, I'm going to guess somewhere around, 350, 350 counts on here from what it looks like. So each one of these has all those counts, and this is your entire, 5-minute image that you did, broken up into those cycles and laid on top of each other. All right, so now we need to talk about ejection fraction, okay? And this is one of the main things that we're after when we do a Muga scan is to get the ejection fraction. Ejection fraction is essentially, if you want to put a definition on it, you think about what we're imaging the filling of the ventricle, right? How full the ventricle is. And so the ejection fraction is just a calculation between diastolic and systolic. When it's diastolic, it's nice and full. So we want to know how many counts are there. And then when it's contracted and it's end systolic, we want to know how many counts are still there. When you subtract those counts out, what you're going to find is you're going to find a percentage, and that's going to show you how much has been ejected from the heart. So this is cardiac function right here. This is volume function. And so the way you calculate an ejection fraction I've put here. Now, I tried to make this, they're not real numbers because I tried to simplify it so you could see the math and not use 1,000 count, 350,000 counts or whatever. And so I just made the numbers really simple. So what I've done here, I've gone to diastolic first, and I've drawn an ROI. And then I've also drawn a background. When we do ejection fraction, it's going to separate out the background from the ventricle. Obviously, we don't want these two, the right and left ventricle, superimposing, but also by just inherent nature of nuke med scans, we're going to have some free tech, some superimposition. Even when you don't have free tech, you got to realize that your lungs also have blood flow to them. So there's going to be some activity in other areas. And so we want to be able to subtract that background out. Now, when it comes to a Muga, it's sort of important where you place your background. It doesn't have to be perfect, but I want you to think in terms of where is my heart sitting? Well, it's sitting surrounded by lung tissue, and there's actually lung tissue that comes behind. It's sitting kind of the front of the heart, and so you've got lung tissue kind of surrounding that. And so that's a really good idea for background is to try to get lung tissue. That's your main background that you have. So in other words, if you draw an ROI, you don't want it clear up here by the shoulder out in nowhere. You also don't want it clear outside of the body where there's no counts, because that doesn't help you to truly subtract what is background. And so I've drawn that ROI kind of right here in what would be the lung field. Okay, and that's why I did it that way. So you're going to have your ROI on diastolic, your background. You're also going to do an ROI on systolic with the same background. And then in terms of the math, what it is and I've written it right here for you, but the ejection fraction equals end diastolic volume minus the systolic volume divided by the end diastolic volume. Okay, so I made up these count totals, but let's say we have 7,000 counts here. So I did the 7,000 minus 1,000 counts, which is what's represented here. And that's going to be subtracted by end diastolic, which gave us 3 counts for the heart and 1 count for the background. Okay, that's what I've represented here. And then we're dividing that again by the end systolic, which we've already determined was the 7 minus 1. So if you do the math here, what you're going to get is 0.66. To get an actual percentage number, then you would times that by 100, and that gave us an ejection fraction of 66%. Okay, so that's how ejection fraction is figured out. You'll probably never have to do it on your own. This is something the boards could throw at you, but ejection fraction is the same principle for HIDA scans or for anything else where we do a contraction in nuke med. This is the basic equation for ejection fraction. Other thing I want you to take note of here is that a normal ejection fraction is between 50 and 70%. Okay, so when we do our test, docs pull it up, they're looking for that number. They want to know what's the EF, and then the normal range is 50 to 70. You definitely should know that number. Not just for my testing, but that's a boards type question as well, a normal ejection fraction for left ventricle. The other caveat I'll throw in here, and we'll talk about this a little more when we talk about our perfusion scans, but when you go from a rest scan to a stress scan, that percentage should increase by at least 5%, right? Because when you exercise, you're going to start getting a harder, more forced contraction. And so it should go up a little bit by 5% at least to be normal. Okay. Any questions on any of that? Okay. You guys can still hear me? We're not getting glitching or anything, are we?
We're good.
Good. Okay. Thanks, Dallin.
I
Awesome.
actually did have a question.
Yeah, shoot.
So what if so you did say the 50 to 70 percent. What if it's above that?
Above is okay, although that can, depending on what's going on with the patient, that could lead to some other things. Like there could be some hypertrophy. There can be a few different things that could cause that. I don't know that you necessarily need to know that for what we're doing here, but it can be above 70%. It can, but the normal is 50 to 70.
Thank you.
Mhm. Okay, so what I want to get into now is we're gonna look at the data that we create when we form these images. There's a bunch of stuff that it spits out. Remember at the beginning, we talked about ejection fraction, which is a big portion of why they do this to get that number. But there's also, I mentioned at the beginning that one of the reasons we do this is for assessment of wall motion. In other words, wall motion just means how is the heart beating? How is it moving? Is it moving in the way we expect a heart to beat, or has it got some sort of funky type of movement to it? And so that's what that's going to help us with is all this other data is looking at those that secondary data to determine wall motion. So that's the thing I want you to think of here. So I'm going to go through all of these data sets, and when you do your processing on your whatever software you use, it probably won't look exactly like this, but you should expect to see most of these data sets. you could be, one less or one more. It's probably going to be these data sets, though. This is the typical of what you see and what they look for. Your books talk about these data sets as well. And so I'm going to go through and kind of show you what all of them are. I would say that generally you need to understand these for purposes of, understanding what you're giving to your doctor. And as you look at this at the end, if something looks weird or out of place, maybe you did something wrong, whatever. So I generally understand these. I doubt that you're going to get like a board's question on, tell me about amplitude and phase imaging for a Muga. I wouldn't necessarily expect that, but I do think that you should understand these and know them in a general sense, for being a good tech and producing good images and things like that. So we'll kind of go through these step by step. So this first image all the way up here in the upper right, this is basically like this is a framed image that's formed in a kind of like a cine. And unfortunately on what I've got here, I could only take a screen capture of it. And so when I pull this up on my software, all of these are static images, but this one is actually the computer goes through the frames like a cine, like a movie. So you can actually see the contraction happening. It'll be sit there beating, which is a nice view for the doctors to look at. They're going to have all this other data that I'm going to show you, but it's nice to look at that and be like, okay, what do my eyes show me? If I can watch this heart actually beat and contract, what do my eyes show me? So I would recommend, even if you guys don't do many Mugas, have one of your techs pull up maybe one they did a long time ago or whatever, and they should have a cine image like this, and you can look at it. It's actually kind of cool to see that actual beat happening. So go check that out. So that's one of the things that will likely be come up in terms of data sets. The other two that we kind of start with are going to be the calculation of ejection fraction. Now, when you go through your processing software, some of your software is going to require you to do a manual ROI and calculate ejection fraction. And some of your software will do, the computer will do it itself, right? And then some of them, maybe your docs want both. They want your computer to do one and then you to also do one and kind of view those two. I've actually done cardiac studies where docs wanted both of those two options. The one I'm showing you here is done by the computer. And so this top image on the left, this is the computer went through and it said, this is where I think the ventricle is. This is my diastole image. And so again, the heart's relaxed and the ventricle is completely full. And then the image just below here, this is our systole image. And so this is at contraction. The computer also did another ROI with a background. And so the computer is using these two images to calculate that ejection fraction. And my ejection fraction number is spit out right down here. And you can see that it actually tells me how many frames it used. So it used 122 frames to get those pictures. It also shows me the counts that it had for each of those. So at diastolic, when it was relaxed and full, it had 5,266 counts. When it was contracted, it had 1,766,000 counts. So it was able to gather plenty of counts to get those two images. And then it also shows the background here. And those are the numbers, just like in the equation I showed you a minute ago. It used all those numbers, did the exact same equation, and then gave us an ejection fraction of 66. Okay, so that's kind of your two basic pictures just for ejection fraction. The next two are what we call amplitude and phase. I want you to, a lot of the rest of these pictures are, the way I would say it is that they are a static representation of dynamic data, meaning data that's actually showing you something about how the heart is beating. That's dynamic, right? So it's not like a cine where we see it moving, but there's information here that's going to tell us how the heart was beating. So that's kind of almost all of the rest of these show that. But amplitude, what happens in amplitude is the camera pays attention to the strength of contraction as it watches all those frames. It pays attention to where the contraction happened at the greatest, I guess what you'd say is greatest speed and strength. And then what it does is it gives counts to areas of the ventricle that have that greatest or hardest contraction. So if you look at this image, this is the left ventricle here, and you'll notice that down here by the apex, and also up the lateral wall here, you'll notice that there's a lot more counts. I want you to think for a minute, how does the heart beat, right? How the heart beats is you have the septum in the middle and you have the right and left ventricle on those two sides. And that left ventricle, the septum actually doesn't move much. Both the ventricles kind of contract into the septum. So what you normally see on the left ventricle is that the apex will kind of contract upward, and then that lateral wall contracts in towards the septum. And so if you look at that, that's exactly what it's telling us here with strength of contraction, that you had a lot of strength of contraction down here at the apex, up the lateral wall, and you'll notice, oh, when you come up here over by kind of what would be more towards the septal wall, there's not a lot of contraction that happened there. And you notice that right in the middle, that's contraction that never occurred, right? Because when we contract to systolic, there's still volume in there. So what it's done is it's subtracted that volume out. So all it's showing you is counts where there was essentially that force of contraction, okay? So that's what you're seeing here. This isn't, this almost, if you've ever looked at a myocardial perfusion and you've looked at an axial image that looks like a donut, that's not what this is, even though it's looking like, oh, well, is this myocardium and you have the hole in the middle? No, no. This is just the ventricle. Remember, it's just blood inside the ventricle. But because this is a dynamic representation, it cut out all that middle part because that middle part didn't move at all. There was no force of contraction there. All the force of contraction was down apically and lateral wall. Okay, so that's what that's showing us. So that's amplitude. The other one that kind of goes along with amplitude is phase, okay? So what phase does is it represents the ventricles and their filling in one color, and then it will actually do the atrium, which you can see here well in this picture, in another color. And what it's doing is it's going to put it along this histogram that you see to the right. This histogram has strength of contraction. So you're getting some more of that idea of the strength of contraction. But it also, along the bottom, it has degree, what you would call degree of difference. So let me try to explain this in the best way I can. If you had some event or anything that occurred at the same time, you could say that there is 0 degree of difference when that took place, right? They happened at the same time, so there's no degree of difference. If you had something that happened exactly opposite of each other, then you would have 180 degrees difference. And then there could be anything in between. That's what they mean by these degrees, okay? So they start at 0 degrees and go all the way to 360 degrees. What you can see on here then is that our ventricles, which are highlighted in green, you can see that they happened right in here. It's probably somewhere around the 100-degree mark. So this represents kind of when it happened, right? So it's happening at this 100-degree mark, and it's a pretty strong contraction, as you might guess, because it's ventricle, right? The ventricles contract much harder. That's your QRS. We're used to seeing the bigger QRS, right? And then what you see going down here is you see that the atrium are represented clear down here, and this is probably somewhere around, I don't know, 290, 300, right? And so what you'll notice is it's in terms of strength of contraction, it's less because it represents the atrium, which is the P wave. But you'll also notice that these are approximately 180 degrees difference. What does that mean? It means that when the atrium are contracting, the ventricles are relaxed and filling, and when the ventricles are contracted, the atrium are relaxed and filling. So you have this, right? Which is what we want. We want the heart to beat like that so it can fill up in the right sequence, like we talked about at the first of our last class, when we trace the blood flow through the heart and we said atrium contract and push it down into the ventricles, and then the ventricles contract and either go up to lung or to the rest of the body, right? And so that's what you want to have happen, is you want to have close to that 180 degree. And if it starts to get closer in degree, that means there's something wrong with the rhythm, right? They're not in the sync or in a rhythm. So that's what phase is. So that's your amplitude and your phase, okay? The next image is going to be what we call an EF image. And you're going to see that this is sort of similar to amplitude, but where amplitude measures strength of contraction, what the EF image is motion or movement of contraction, which are very similar, but amplitude is more about how fast or how strong it occurred. And EF is just where motion occurred and where motion did not occur. Okay. So where motion occurred is where the most counts are given. So you can see again, what we expect is that we're going to have apical and lateral wall. So this is highlighting a lot of counts where the motion occurred. And again, notice the septum is hardly lit up at all because not much motion occurs there when a normal heart is contracting. And then you'll notice right in the middle, nothing changed, no motion changed because those counts didn't ever change at all. They stayed the same, right? They were always there. So they subtracted them out. So that's what you're seeing there. And then the stroke volume is this next one over. And that basically represents the actual blood ejected during systole. So this is more of a, I would compare it to the same way that you check an ejection fraction where you look at relaxation and then you look at contraction. And all this image is doing is it's showing you the full ventricle when it was relaxed at diastole. And then what it does is it subtracts out what is there during systolic. Okay. So instead of just giving you an EF number and showing counts in both, it's putting those two together and just saying, hey, we'll just subtract out what happened during systolic, during contraction. And that gives you an idea of how much blood flow went out of the heart, stroke volume. So we're looking at this volume. If we were to do a counts here, we would know how much of the heart, or excuse me, how much of the volume of that heart left when it went out to the body. Okay. And then this paradox image down here, this is where it essentially will just show, it'll show activity in the atria that are contracting while the ventricles are filling. So it's we're normally looking at filling of the ventricle. This is kind of like your opposite image to see the atrium as well. And it will only show what's there when the contraction when they're filling. So even though it looks like there's activity in here, this is actually representing contraction. So the blood flow would actually be flowing into the ventricles right now, but it gives it's kind of the one thing on here that says, okay, well, we'll give you a little bit of data about the atrium contracting and how they're doing there. So that's what the paradox image is. This regional EF one is one that I actually think is really cool. And essentially what the camera does is it takes your ROI and it takes the ventricle and it divides it up into slices like a pie. So you'll notice it's just like a pie or a pizza, right? And so what it's doing is it's dividing that up and then it's figuring out an ejection fraction for every portion of that pie. So out here on the lateral wall, we're going to look at what the lateral wall ejection fraction is looking like. That gives us like more precise, right? Here's apical. What's happening apically? What number are we getting there? And what's happening during by the septum, right? So as you can imagine from everything else we've been saying, you should expect that you're going to get a greater contraction by the apex and the lateral wall than you would as the part that's near the septum, right? Less contraction there. This really speaks to wall motion, how those actual walls are moving and what they're doing, and it's separated out so we can see. And you notice on here that you've got like 56% over here on the septum, and then you can't see this number very good, but this one out here by the lateral wall is 69. This apex is 66. So you can see it's getting a much higher ejection fraction than what you would during the septum. And so they can break up each one of these. So let's just say that our apical number was really low, like it came back and it was like 45 or something like that. What the docs could say is say, okay, something's happening apically. What is it? Am I getting, maybe I have a blockage and there's reduced blood flow to the myocardium. And so I don't have blood flow there. So I'm not getting a good contraction. Or maybe there's something going on electrically down here. Maybe these Purkinje fibers are not getting an appropriate contraction. Maybe there is some heart failure and you're getting a massive amount of thickening down there. And so you don't get that wall motion and function very well. All those are things that the doctors can look at and say, okay, we've got a clue here that something's going on in this particular area. Okay. And then the last thing that's on this page is this is a histogram contraction of every one of those frames. So down here you've got time, and then these are your count values, right? So it's just mapped these out, and basically you can just see the contraction of the heart, right? So here you have diastolic all the way down to the most systolic picture, all the way up back to relaxation and repolarization. So that's what you see there. Any question on any of this data and what a Muga scan can get us? Remember that I can't see you, so if you have a question, just shout out. Okay. I got one more picture that I want to show you. Let's see if we can get this going here. So I wanted to bring this one up because there's a couple of first of all I want you to see one that's a little more abnormal. And secondly, I want to identify some terms that you're going to hear when doctors or techs talk about wall motion and they're identifying it on things like reports and stuff. So we have all the same data here. As you kind of cruise through and look at this data, there's a couple interesting things. The first thing that's really interesting is that if you look at your phase, you can see that the phase for the atria and they're kind of right together. So my guess here is you probably have a heart that has a rhythm issue. Um, those aren't happening in the right respect of where they should be. So either a rhythm issue could have a myocardial blockage of some kind going on. Maybe those can cause the heart to beat funny as well. If you're not getting blood flow to the muscle, it can't do its job like it should. But definitely you're seeing what a difference looks like, right? We expect those to be 180 degrees apart and they're almost on top of each other. So some interesting things there. I wanted to mainly point out the regional EF image because I think it's interesting. This is kind of what I was talking about before. You'll notice that kind of out towards the lateral wall, you get a 69. And then as you come down in towards the apex, you're coming down to 57, 47. And then septally, you're actually getting a greater contraction. And so this was kind of what I was mentioning before, where we can tell that, okay, our problem is somewhere down in the apex, right? That's where we're having issues with why we're having contraction issues with this heart. Something's going down in the apex. So with that kind of idea in mind, let's look at these terms that you need to know. So we have three terms that I kind of want you to know: hypokinetic, akinesis, and dyskinetic. So hypokinetic, if you just break up that word and think about it, it's really easy to remember what it means because as you know from lots of other medical things, hypo means low or diminished. And then kinetic is just another way of saying motion. And if anything, if something's in motion, it has kinetic energy, right? And so essentially hypokinetic means diminished contraction. So what you might see a doctor say on this is that they might report it as hypokinesis in the apicolateral aspect of the heart or the apicolateral wall of the heart. That would be hypokinesis. The next one is akinesis, and that means absence of wall motion. So the wall, you're not getting motion at all. Now, we obviously expect less on the septal side, but we still expect some. If you were to find that there's one of the walls that just isn't moving at all, it would be hypokinesis, and that would be reported as hypokinetic wall motion in whatever area. And then the last one is akinesis. And akinesis, oh, sorry. I looked at that and just repeated it. It's dyskinetic. So dyskinetic is what we would call a paradoxical wall motion, meaning that where we expect our wall motion to contract on systole, you might have a wall that actually goes out. It like bulges outward. So it does the exact opposite of what you would expect. And that's what you would call dyskinetic. So a dyskinetic wall motion may be reported on a scan. And that's what that means is it's going the wrong way for some reason. So those are three terms. I do believe I put those on my test, and those are good terms to know as you're going throughout cardiology. Those could be board questions, or at least to understand. They might ask a question like, "What can be assessed on a Muga scan?" And maybe they would give you options like hypokinetic, akinesis, dekinetic, dyskinetic, things like that. So all those can be. So know those terms. And again, like I said, generally the data, know how to do this, know the protocol, know how important it is to get that LAO image in the right spot. All of those things, know how to set up your EKG and get a good gate and how to look at that. And again, I would highly recommend, especially where you guys might not have as many opportunities to see these because we don't do them as much as we used to. Um, get with one of your techs so you can get some hands-on and at least looking inside the protocol and look at past studies so you can get an idea of what they do and ask your tech about it. Ask your tech to show you these things if you're not seeing them because it is still on the board. So any questions? That's all I've got for you today. Is there anything that you want to know? I won't go off the slides yet in case there's questions there. So speak up if you have a question. Okay. I'm gonna take that as no, so I'll stop sharing slides. Okay. Just gonna take a quick peek over here. Did any of you that put something over here in the messages that I didn't see during that, was there anything we didn't answer that you wanted answered? Syringe, 1, 2. Oh, you know what else I did want to say? Now that I'm thinking about it, if ever you're in a situation where you need to tag red blood cells, whether it be a GI bleed or whether it be a Muga, if you're ever confused at what to do and you're kind of like, what should I do? Um, every one of those kits comes with an insert. So it'll have a little package insert. And if you open that up and it's folded into like 1,000 folds, but you open it up, there's instructions and it's listed out exactly what to do in what order, how much time to wait, what to do, all that stuff. And so look at that because that'll save you every time. I mean, honestly, for the first several years I did nuke med whenever I had to do a GI bleed or whatever, I would just get that out. I would just follow it. Even though I kind of thought I had it in my mind, I knew what I was doing, I just would follow it so that I knew I wasn't screwing it up and I didn't get a bad tag. The last thing you want to do is get a bad tag, especially if you've ordered a dose, you don't have like a bulk Protecnitate. You've ordered a specific dose and now you've gone and got the blood and you've done all this work and then you've put the kit together, you've made the blood, you've waited the 20 minutes, and now you go inject it into your patient and you don't have a good tag. It sucks. I'm going to knock on wood. I have not had that happen, but I've been with techs that it did. They didn't get a good tag for some reason or another. So I would say take your time, be particular, follow the instructions on those if you need to, and get a good tag. I'm going to guess no other questions. I kind of put that out there. Let me make sure. Yeah, cool. So that's kind of what you guys said over in the comments. Awesome. So then the only other reminders I would say is that your test is available. Again, it's for section 1, both the A and B. And so go ahead and get that taken. And then next time we meet, we're going to get into stress testing, which I know you're probably all like just wanting now because you're probably doing that the most. So we're gonna have an awesome big lecture next time. We're gonna get into all of it. We're gonna try to answer all the questions I know you have and get into how you do it and protocols and what to expect and all the good stuff. So I will see you next time unless there's anybody else that has any more questions.
Thank you.
You are very welcome.
Thank you.
Yep.